Okay, so we need to move on because we are running behind time. So the next talk is on behavioural responses to pharmacogenetics, and Alison Wright is going to take us through that. Hi, Alison.
Brilliant. Just let everyone grab their seats. Brilliant. Well, thank you very much for the invitation to share some of our work with you this morning. Okay, so as we've heard earlier, there are plans to examine how pharmacogenomics can reduce adverse drug reactions and improve the effectiveness of medicines prescribed to NHS patients. And when using pharmacogenomics, it is essential to consider what the impact of this new method of informing prescribing is going to have on patients. And we've already heard there's important work being done on things like the acceptability of pharmacogenomics, patients' understanding of it, their concerns and their information needs. But what about their behavioural responses? What's their understanding of why they've been prescribed a particular medicine? What are their beliefs and their expectations about their medicines after pharmacogenomic prescribing? And how does it affect their medication adherence? So why do we care about medication adherence in the context of pharmacogenomics? Well, as the US Surgeon General said a couple of decades ago now, medicines don't work in patients that don't take them. And I'd like to add that pharmacogenomically guided prescribing does not benefit patients who don't take those medicines. So it's often been suggested that pharmacogenomics will actually have the potential to increase medication adherence, and this is both in the literature and also, if you heard, it comes out of some of the PPI work with patients who might be affected by this technology. But let's look at that in a bit more detail. Firstly, what does the evidence to date say about the impact of pharmacogenomic prescribing on medication adherence? Secondly, what does behavioural science suggest about the potential impact of deploying pharmacogenomics within the NHS on patients' medication adherence? And thirdly, what questions remain and need further exploration? So I think it's helpful at this point to actually define what we're talking about by medication adherence. And one very commonly used definition is the extent to which the patient's behaviour matches agreed recommendations from the prescriber. And it's also generally recognised that adherence has three phases. The first of these is called initiation, and this is about the gap between when the prescriber issues the prescription to when the patient takes the first dose. The next phase is implementation, and this is about the extent to which the patient's dosing of their medicines matches the prescriber's recommendations after the patient has taken that first dose. And then finally, we have discontinuation, which is the point at which the patient takes no more doses, and that might or might not coincide with a recommendation from a prescriber to stop taking the medicine. So I thought it might be useful just to sort of think about how big an issue is medication adherence. And I looked at it for some of the more common drugs that have actionable gene drug variants, perhaps in primary care. So primary non-adherence, which is when people don't even initiate their drugs, they just get the prescription and nothing more happens, runs at about 25% in statins and about 12% in antidepressants and proton pump inhibitors. When we look longer term, we see estimates in the sort of 40 to 45 range. So that's a lot of doses of medicine that are not being taken as expected. In terms of the impact of pharmacogenomic prescribing on medication adherence, the literature to date is relatively sparse. So I've tried to summarise it here for you. I'm sorry, this is a little bit of a dense slide, but I will try to run you through it. So in a case control study in the States, they looked at the impact of using a particular variant to guide prescribing of statins. And they did find higher adherence at 6 months in the tested group versus the non-tested controls. This study is a little unusual in that statins are described as for prevention, and the information given to patients described the allele as both increasing the risk of heart attack and increasing benefit from statins. So we don't know which of those two facts drove adherence. And that's important because in a lot of cases, when you apply pharmacogenomics, it will be to people who already have an illness. They're not at risk of an illness. They know 100% they have that illness already. The second was a multi-gene panel, and this was the only one I could find that had used a multi-gene panel in a case control study, and they found no significant differences in adherence overall. And while we're told that they presented pharmacogenomic testing results using some kind of traffic light approach, they don't give us the detail of what exactly that involved. So we don't know the wording, we don't know what was shown to clinicians, we don't know what clinicians said to patients. Moving on to look at RCTs, we have one using a particular marker to predict statin side effects, and this was in patients who'd previously stopped statins because they'd experienced myalgia, which is not rhabdomyolysis. And there was an early indication that pharmacogenomic testing might have helped get people come back to being prescribed statins, so there were significantly more new prescriptions. But this did not translate into a significant difference in adherence among the people who accepted a new prescription at 3 months. And finally, a trial in which I was involved in the UK, using a mu opioid receptor gene to guide dosing for nicotine replacement therapy in the people who wanted to quit smoking. And in this trial, we found significantly higher adherence at 7 days, but not by the time we got to 28 days. So bringing together what this suggests to me is that firstly, the evidence base is pretty sparse. There is hope, but we do not have the evidence yet to say with certainty that, yes, this is going to increase adherence. And it also looks like actually the benefits might particularly accrue early on in the patient's journey with taking their medicines. So soon after prescription might be the time when pharmacogenomics makes the most difference to medication adherence. Let's have a think about how prescribing might affect early adherence. So let's start from the point that a pharmacogenomic result is provided to the healthcare professional. They then need to communicate that result and its implications to the patient in some way. Depending on the particular drug gene variant we're talking about, that communication might either reduce the patient's concerns about side effects, or it might increase their perceptions of how effective the treatment's likely to be for them. And we have really good systematic review evidence in psychology that reducing concerns about side effects and increasing treatment effectiveness improves adherence. But there are some important variables that might interact with the arrows on this pathway. So firstly, thinking about how pharmacogenomic information gets communicated to patients by healthcare professionals, I think this is going to depend on how the results are presented in any clinical decision support system. So the particular wording that's used, very often people sort of use the words they see on the screen to talk to patients. And then also the healthcare professional's own understanding of pharmacogenomics is going to affect how they communicate that result to their patient. And then in terms of the impact of the communication on patients' beliefs, there's lots of things that will vary according to. So firstly, the particular language used, how things are framed, patients' trust in healthcare professionals and so in the information they're getting. How well this information fits with the patient's understanding of illness. So does it make sense to them that the treatment for their illness might in some way be guided by something genetic? And also people have prior ideas about treatment. Even if they're new to taking the treatment themselves, they'll have seen other people taking it, whether that's among their friends and family or perhaps via the media. So people are not a tabula rasa when it comes to presenting them information about medication effectiveness and side effects. They have existing ideas when we come to communicate with them. Moving forward, let's think about we've got someone started, they've got to initial adherence. What happens then? This is where the experience of symptoms becomes essential. And I'm sorry, one of my arrows has gone a bit wonky, but never mind. So basically, people's lived experience of what happens when they take medication starts to become an important predictor of adherence. And in particular, people ask themselves, based on these symptoms, does it seem like my medicine's working? And this can lead to changes in their ideas about perceived effectiveness. Symptoms that they attribute to being side effects of the drug, so it's not 100% straightforward. Not everyone with a muscle ache will think, oh, this must be due to my statins. Some people might think, I clearly overdid it at the gym. So people who attribute their symptoms to their medicines are going to think about things like how bothersome are these and are they what I expected? So there is an issue if we tell people this medicine is less likely to give you side effects and then actually they still encounter some side effects because we're not going to 100% eradicate side effects. Actually, how do they react? And this is going to change their concerns, which in turn is going to affect their longer term adherence. The other thing we need to think about is that actually Beliefs about medicines and concerns about side effects are not the only things that affect adherence. And one model that's used very often to explain the multitude of factors that affect behaviour, and that's based on extensive evidence syntheses, is called the COM-B model. And what this says is the C is people's capability, so your physical and psychological ability to do the behaviour, so to be adherent. The O is opportunity, which is all the things outside of a person that nevertheless affect their behaviour. So there's physical opportunity, which is their built environment and the environment around them. And then there's social opportunities, the social groups and milieu that they're part of affect their behaviour. And then finally, motivation is people's beliefs, intentions and goals. And this is where treatment beliefs might come in. So they're one of the things that can contribute to motivation to be adherent. So, where are we now? There's hope that pharmacogenomically guided prescribing is going to enhance adherence because it could increase patients' ideas about how effective their medicines are going to be and reduce their concerns about possible side effects. The evidence base to date is very sparse, but does slightly suggest that there might be particular advantages in reducing primary non-adherence. And this might also be because symptoms become a bigger guide to adherence once people get started on a medicine. There are nevertheless potential benefits for promoting longer-term adherence, this sense that this medicine is special to me, and that actually, it might lead to a symptom experience that is more indicative of this medicine is working, I'm not concerned about my side effects. But we should remember that non-adherence is influenced by multiple factors, as suggested by the COM-B model, and not just patients' perceptions of their medication. And I think we're left with some interesting questions to explore as pharmacogenomics is further rolled out. So things about how are healthcare professionals communicating pharmacogenomic results to patients, and how does this impact on the patient's expectations of treatment effectiveness and side effects in actual clinical scenarios where this information is being communicated for real? Are there ways that healthcare professionals can communicate pharmacogenomic test results that better support adherence? What are these? Can we train people in them? We can think about how the presentation of results within a computer support system affects how healthcare professionals communicate about pharmacogenomics with their patients. And I think another interesting thing is actually thinking about how behavioural responses will change as we move from reactive to preemptive testing. So some of the studies I showed you earlier were reactive testing. Sometimes there are a 30-day lag, whereas actually if we get the test results back to patients faster, is that then going to have a bigger impact on their adherence? Thank you.
Maybe time for one question. Please.
Thank you very much for a really nice presentation. Thank you for a great presentation. It was really interesting. I had a question. I loved how you've talked about the healthcare professionals communicating this information. Do you have any views on patients receiving this information directly themselves and how perhaps that may or may not have an influence on their adherence?
Absolutely. So we think that patients will make sense of this information by fitting it with what they already think they know about the illness and about ways to treat that illness. And when patients are thinking about ways to treat an illness, they're thinking about medicines, but also about other things they might have tried. So like with statins, you hear quite often people saying, oh no, I prefer diet and exercise. And sometimes it's only when diet and exercise have failed that people then accept that they need to be on a statin. So I think for patients making sense of it, their pre-existing beliefs about what is this condition, what are sensible ways to treat it, what have I tried before and how effective it is, are all going to make a difference to what they hear from the healthcare professional.
Thank you.
Thanks very much. We've got time for another question, actually. We've got 1 minute and 16 seconds left.
No pressure.
So, Alison, in the PREPARE trial, we didn't measure adherence, but we were criticised for including grade 2 adverse events into our outcome measure. And we included that because of adherence issues, because it's mild adverse effects or moderate adverse effects are important to patients. They stop taking the medicines. That's why we included it. And so it's been quite difficult to explain it to geneticists. That's why we included it. Actually, because they say, this is no, so you used to only include grade 3 or grade 4 adverse drug reactions. Yeah. But I think grade 2 are really important to patients as well.
Hugely, I would completely agree with that. And I think that's one of the really important things, that to patients, it's not just the things that sort of concern us that get classified as SAEs in drug trials, but actually those little things, constipation, dry mouth, dizziness, actually, they can really disrupt your day-to-day life and reduce your quality of life. So I think you're very right to include them.
Yeah, I learned that as a junior doctor when I saw a patient who had grade 3 liver function test elevation, but she was asymptomatic, but she was much more worried about grade 2 constipation. So, I got that from the patient. Thanks very much.
Thank you.
Okay, next is a very important area, education training. Really important area. We need to upskill our workforce. And so Jess and Emma are going to do a double act on this. Thank you.
Thank you very much for the invitation to speak today on what I think I can speak for Emma and I and a number of others in the room is maybe one of the most important areas of implementation, which is how we educate and train our NHS workforce. And what I'm going to do is I'm going to kind of lay out all of the challenges and then hand over to Emma, who's going to tell us how we fix them through the Network of Excellence and our collaborative partners. So what I really wanted to do first is talk about some of the challenges. And I think we've heard a bit today about, the scale and how common this kind of genetic variation is. But what does that actually look like in the context of the NHS? And so in England alone, you can see the statistic here from 22-23 that the cost of prescribing was £19.2 billion that year, and that is increasing year on year. And actually half of that prescribing budget was spent in primary care, over 1 billion drugs, and that's again going up every single year. So when we're talking about the spread, it is absolutely vast. Prescribing is the most common intervention, and it's happening all over the system. In practice, in numbers, what does that mean for pharmacogenomics? And there was a group a couple of years ago led by Elvira who looked at the number of new prescriptions in primary care where there was an actionable gene-drug interaction, and that was 5.5 million. That was what they estimated at. So that is medicines that were prescribed newly, not just with pharmacogenetic guidance, but actually where the person was likely to have a genetic variant, which would mean they would need their dose change, they would need a new medicine, or they might need increased monitoring. So that's huge numbers, and again, that is just in primary care. And actually, the scale is even bigger if you do it over a longer time. So up to 80% of people over a 20-year period will be prescribed a medicine with pharmacogenetic guidance. So when we're thinking about scale, I think massive is probably a fair assessment. But what about the workforce? And there are a number of different studies that have been done in various different professional groups. A lot of work's been done in pharmacy colleagues, but also in medics and nurses. And what you can tend to find, the themes that you can pull out is there's a lack of awareness, experience, and confidence in this. A survey just a couple of years ago by the Pharmaceutical Journal and pharmacists showed that only about 10% of pharmacists who we think are a really key workforce feel that they are very prepared to implement and use pharmacogenomics in their practice, and actually almost half said they felt they are not at all prepared. And we also know that there are huge variations in where people get their pharmacogenomic education from, and this varies across professions, but also in how recently you were educated. So the majority of people who've received any pharmacogenomic education had that undergraduate level. But for some people, we've also seen that if that was in the last 10 years, that's fairly high. If you've been qualified for 10 years or more, that significantly decreases, and there is this big variation. And so we need to think about that when we think about our workforce. It's not just about the newly qualified, it's actually the people who've been practicing for a long time. And the access to resources across the continuum of education, which I'll go on to in a minute, is really variable. We've got this lovely graphic here, which is from Genomics Education, and they talk about the kind of stepwise ladder of learning and how people might start with introductory fact sheets, kind of bite-sized learning to get them interested, see if it's something that is relevant to them. Then they start looking at different levels of resources right up to kind of postgraduate education. The other thing that we really need to think about is our approach. So people's needs are very, very different across the sectors that they work in, across their specialisms, across their professions and their roles. And so what we need to do is not just develop educational resources, but actually make sure that people know what is relevant to them. What is it that I need to know about in my day-to-day job? Is it relevant to me? And what's the level of knowledge that I need to perform my duty? We also really need increased numbers of mentors and supervisors who can actually help people understand this. And we know for sure, and I'm sure Emma's going to talk about, that we need to meet a wide variety of needs and learning styles. Some people are very organised, proactive learners. They hear about a topic like this, they want to know more, and they go off and find these resources. But actually a huge number of people, and I include myself in this, are quite reactive. They're not that interested until they're presented with something. And I include myself in that because although I'm here, I wasn't interested in genomics particularly until one day somebody told me I had to check a DPYD result before I could screen my chemotherapy that I was trying to do. And that got me interested. That was what I reacted to. And then I can go and embark on some other type of learning. So what are the roles that people do? And when we talk about these different roles that need to be relevant to their role, they're hugely varied. So this can be for advocating for testing, for a patient or a cohort, taking the sample, ordering the test, maybe giving a recommendation. You might be prescribing or administering a medicine now that you have a result, but you can also be counselling patients, looking at the health informatics implementation at your organisation. Maybe you're educating others or developing guidelines. And all of these roles have very, very different needs. And they're undertaken by different people. Who is the workforce? Who are these people? A lot of them are in this room. Most of them aren't. Most of them are in the workplace delivering services for their patients. I put prescribers here specifically rather than doctors. I think doctors who people tend to think of as prescribing, but actually we know that prescribing workforce is very much changing. It's multidisciplinary. Advanced nurse prescribers, pharmacists are now routinely prescribers. I've put pharmacists as a separate role group. I would do because actually they're involved with the review of these prescriptions and have that increased medical knowledge. GPs I also put separately just because of their importance in polypharmacy and ongoing patient management. But also we have nurses, genetic counsellors, pharmacy technicians, and so many other roles. I can't list them all on this one slide. What's already expected? So when we talk about educating people, what are they expected to know? And I'm not going to go through these examples, but you can see these three important curriculums or competency frameworks, and they already mention that people are expected to know a little bit about pharmacogenomics and genomics, perhaps in relation to medicines, to make better use of medicines for their patients, for the people under their care. So what is the continuum of pharmacogenetic education? That's how we like to think of it. I think that helps us kind of compartmentalize how we might approach educating the workforce. And you can see that we think straight from pre-registration, undergraduate education, what are the core pharmacogenetic concepts, which might be, I guess, applicable across different professional groups. So what's the core knowledge that people just need to understand how this genetic variation is relevant to medicines and the context of that in their own professional life they will see later. So post-registration, we're thinking about contextualizing that knowledge. Okay, I learned about this at university and now I'm seeing it in practice. And how we might educate people, not just in the workplace, but also through postgraduate training, diplomas and so on that people undertake after they're officially qualified. But also we need to think about workplace education. So what are the ways that people learn in new things to undertake their role? So that could be continuing professional development, information that's presented to them as required at the point that they need it. Not everybody is going to go back through training just to pick up this information. So we need to think about how we can access people in the workplace. And then what we really also want to focus on is the extended roles. What about people who do decide that pharmacogenomics is a specialism for them? They might need to know different things and have a much different access to different resources because they're trying to act as leaders in this area. They're bringing their clinical expertise. There's somebody that people can refer to if they're in the normal workplace, but there's a different variant, something looks different, and they want something to refer to, maybe a multidisciplinary approach there. So without further ado, I'll hand over to my esteemed colleague, Emma.
Thank you. So building on the continuum that Jess has just spoke through, we need to think about how we can support that continuum of pharmacogenomics education. And the home of genomics education is the National Genomics Education Programme in England, and they're there to upskill the entirety of the NHS workforce in genomics more broadly. And they have a whole host of tried and tested tools and resources that go through that learning ladder, right the way from bite-size resources and fact sheets up to fully funded MSc modules. In terms of what is there in terms of pharmacogenetics specifically, we can break it down into two different types of educational resources. So as Jessica explained, we have those proactive tools for colleagues who recognise that pharmacogenetics is an evolving area and relevant to their practice. So they'll go off and do specific learning. The Centre for Postgraduate Pharmacy Education does provide a 2-hour package for pharmacy professionals, and that covers the very much baseline core concepts, and we regularly promote that to colleagues. In terms of the multidisciplinary space, the Genomics Education programme do provide an MSc module in pharmacogenetics and stratified healthcare, which is free for NHS professionals and is brilliant, but there is a challenge in the workplace that allowing people the time to go off and do a full MSc course can be challenging. And we also know that the vast majority of people are reactive learners, so 80% of the workforce will engage with education when they recognise that it's relevant to their practice and to patient care. And to fill that gap, the Genomics Education programme have an initiative called G-Notes, which is great, and they have a pharmacogenomics set which goes through key cases of where genomics is relevant in patient care to support the upskilling of the prescribers who need that information just in time. But what do we still need? I think there's a whole host of work that we can do collaboratively in this space. And if we start with the centre of the diagram, it's important that healthcare professionals are able to understand the relevance of pharmacogenetics to their role and that they have the right level of competence for practice. And there's a real role here for professional leadership across the professions to understand how pharmacogenetics fits into prescribing of medicines and those pathways. And then at the other side of the diagram, the proactive learners, there is work to be done in terms of developing those introductory hooks in and those bite-sized resources to understand why pharmacogenetics is relevant. And then on the other side, so the vast majority, 80% of the workforce are the reactive learners, and it comes back to decision support, and a lot of the evidence that's built up from primary care is that GPs and those working in primary care often learn through clinical decision support alerts. So it's super important that they are designed in a way that supports education. And again, linking back to that, education isn't just about that formal education. The availability of robust guidelines that are from reputable organisations and with professional authority, again, will support that education and embedding into practice. So how are we going to get there? We've got quite a bit of work ahead of us. I think it's going to be an exciting journey. And this is possibly the most important slide because it's very much about collaboration and partnership working. So working collaboratively across the genomic medicine services in England, but also working in partnership across the UK and devolved nations to make sure that we're sharing resources and tools. The National Genomics Education Programme are a key partner in this space. It's a privilege to be here within the UK Pharmacogenetics and Stratified Medicine Network, who've been a leader in this space for many years. And it's important that we bring in other professional bodies as well as we think about how this fits within professional practice. So thank you for listening. As Jessica said, we're here representing many colleagues who are driving the way in education. We wanted to say thank you to those too.
Thank you. And you got 1 hour, 1 minute, 53 seconds for questions. Please.
Thank you for your talk. I'm coming at this as a medical student who recently had this mandated in our curriculum, but not tested on our boards. It was just sort of a frontiers in medicine lecture. And what came of that is a year later, after that lecture, I do research in this thing, so I like knowing about it. But I have 119 classmates who just don't care. Is there any interest in just not relying on, I guess, altruism and general decency of wanting to do more for your patients and just make it mandatory? Force everyone, put this on their boards, and make it something that people just have to learn, and then you don't need to do outreach.
I completely agree with you. We would love this to be mandatory within undergraduate education for multiple healthcare professionals. That's a very strategic approach. But we've got to bear in mind that there's a whole shopping list of priorities and how we can advocate for this maybe as part of teaching. So if you're teaching about clopidogrel, then you build in pharmacogenetics rather than it being a standalone subject that it's not special, it just fits in with medicines optimization.
Do you think we should make it mandatory training for NHS people? Remember, how many mandatory training packages do we have to do at the moment? That's adding another one on.
I think there's a lot of pushback on including it as mandatory training because of that shopping list, as Emma described. I think it will become mandatory by virtue of the availability of testing. So you become forced, if you haven't done your proactive learning, you're forced to reactively learn at that point. Ideally, people would go and proactively learn, but we know that's probably not realistic. The tipping point with the availability of testing now means people can afford to be proactive, I think. But as there's more testing, we'll get more reactive learners. It would be great if it was mandatory, though.
So I'm just going to take one more question, if that's okay. Sorry. So.
Thank you very much. I think mandatory is an interesting concept, and I can see the Royal College of Physicians apparently is quite involved in this area. Now, we have a number of very powerful royal colleges in the UK. For example, some of us have close links with the Royal College of Pediatrics and Child Health, and I wonder whether you can provide some guidance as a group as to how we can involve these individual colleges.
I think to an extent there's some of that already happening with the Academy of Medical Royal Colleges coming together and thinking about genomics education more broadly. And we're definitely keen to work with that group as well to include pharmacogenomics as a kind of not special but distinct aspect of genomics, if you like. But yeah, to completely take your point, thank you.
Great. Thank you very much. Okay, next talk is from Professor Elvira Bramon, who works in this is a psychiatrist by clinical background, and she's going to tell us about the work she's been doing in mental health. Thank you.
Thanks so much for the opportunity, for inviting me. I'm going to give you an overview of pharmacogenomics in the niche area of mental health. And I'll start by doing a very quick review of the literature, and then I'll show you a couple of studies as well. So in terms of pharmacogenomics for depression, there's actually quite a lot of evidence, more than people give it credit for. There's been over 10 randomized controlled trials comparing people treated with depression, people treated with antidepressants as usual, or people treated with antidepressants that were guided by a pharmacogenetic test. So much so that there's also a meta-analysis, quite a recent meta-analysis combining the data from all these previous RCTs. And what the data shows is that there is a modest yet significant and very clear advantage for the pharmacogenetics guided treatment with antidepressants compared to antidepressants as usual. They measured mostly remission rates, and they found that patients who had the pharmacogenetics test were clearly more likely to achieve remission of their depression. Of course, this looks very encouraging. 40% more likely looks very good. This literature has some limitations that I can tell you about if you want, but in the interest of time, I'll continue. What about psychosis? So this is work that I did with Nushin Sadulakani, who is a PhD student in my team that I'm very glad to be her supervisor. And we did a systematic review of studies that compared treatment as usual with antipsychotics for psychosis, and then treatment guided with pharmacogenetics. There were only 14 studies, but the majority of them, 10 of those, had a mixture of people with psychosis, depression. It was a combination type of approach. Nothing wrong with that, but it was very difficult to tease apart. Psychosis would always be like the minority of patients in those studies. So it was very difficult to establish what the benefits might be for people with the most severe illnesses like schizophrenia, bipolar disorder. There were only a handful of studies that focused on psychosis patients, and they showed some mixed picture. So in terms of reduction of adverse drug reactions, it's very difficult to see in the slide. This is accepted in Nature Mental Health, so soon you'll be able to see it a little bit better than here. But just to give you the gist of it, some studies showed an advantage of pharmacogenetic treatment with antipsychotics in terms of reducing adverse drug reactions. Some studies showed no difference between treatment as usual and guided treatment. And the same happened for symptom reduction. Some studies showed an advantage of pharmacogenetics and some others showed no difference. So it's a bit of a mixed picture with overall relatively limited evidence. When it comes to health economics, the picture was a bit more consistent, and the studies converge more to this idea that pharmacogenetic testing is cost-saving. But if you ask me about data about cost effectiveness, that's very, very sparse. So there's limited evidence in terms of psychosis. The other thing that is very clear, both from the depression studies and the psychosis studies, is the lack of diversity. All the studies are done in North America or Europe. All the participants are, the vast majority of participants are of European ancestry. So there's a clear gap that clearly Emma's study is going to fill that gap. But there's an urgent need to kind of work faster on diversifying the data. And there was no, I hope apart from the PROGRESS study, there's no other UK study that covers, and I think you focus more on depression. So in terms of psychosis, there isn't yet a UK-based study that can look at cost effectiveness in the context of the UK NHS. So with this picture, some solutions. There are two studies that I'm going to present next. This is a study that is starting, and it's led by Professor Alan Young and Dr. Mario Juruena in King's College London. Now, they couldn't be here, so they sent me their slides very kindly, but this is their work. And basically, it's a very powerful randomized controlled trial, a phase 4, 2 parallel arm, multi-center international study looking at pharmacogenomics applied to mental health. They will include people with depression, also people with anxiety disorders, which again, there's very little data on them, and people with psychosis. So again, it's a broad approach in terms of the inclusion of diagnosis. They will randomize patients into two groups, treatment as usual. 875 patients will be randomized. They randomize the actual patients, not the centers, and they will get treatment as usual. And another 875 will get a treatment that is guided by pharmacogenetics. And this is how they are going to do it. It's a classic trial where there'll be a switch of medication. Patients who are eligible for the study will have to switch their current, if they have depression in the depression arm, they'll have to switch their current antidepressant to either take escitalopram or sertraline, and then the dosing, and that's where it gets really interesting, the dosing is informed by their genetic profile on CYP2C19. So poor metabolizers will obviously get a lower dose, and ultra-rapid metabolizers will get doses within licensed limits, but at the upper end. And the same approach for the arm of patients with psychosis. They'll be switched to either risperidone or aripiprazole, and again, the dosing depends on their, in this case, CYP2D6 is their guiding gene, and poor metabolizers low dose, ultra-rapids higher dose. And their primary outcome, I like that a lot actually, their primary outcome is patient self-perceived improvement. So it's a structured scale that's been very well validated that will be basically decided by the patients. And in terms of secondary outcomes, things you would expect. So quantitative, clinician-led measures of symptom change, measures of adverse drug reaction, PAN scores, and also they're going to look at quality of life, which I think that might help with health economics, and they're going to look at social functioning. And then I wanted to tell you about another study. So these two studies hopefully will fill the gaps in the psychosis evidence. This second study is one that I'm running at UCL, and it's called GEMS. It's part of a broader project where we want to study biomarkers of disease risk and treatment response, but we have a very big interest in pharmacogenomics, so part of the study is very focused and very relevant today. And it's funded by the MRC and the NIHR. So the main aims of the pharmacogenetic part of the study are to develop a pharmacogenetic intervention that is acceptable to people with mental illness and their clinicians. At the moment, I think it's fair to say that other than some very occasional use in the private sector that I hear about, I know some colleagues working in private practice have used pharmacogenetic testing, but in the NHS mental health services, we're not using pharmacogenetics at all. I mean, nothing. I think, and a lot of colleagues were a few years ago, a lot of colleagues would look at me blank thinking, what are you talking about? But this is gradually changing. I think partly thanks to these networks that you have developed. So I think it's very, very encouraging, very exciting to see the changes. So in terms of actual scientific outcomes, we want to look as well at relevant clinical outcomes that can help us inform cost effectiveness, and of course, the money. We won't be able to implement this if we don't show that it's a cost-effective intervention. And because there's an upfront cost to meet, not very high and coming down over time, but because there's an upfront cost of testing, if we want to implement it, we have to show that it's going to be cost-effective. And of course, we're also interested in mechanisms of treatment response. So this is the study design. We are in the process of recruiting 2,000 people with psychosis. 400 of them are getting treatment guided by pharmacogenetics. So we send their clinician, we send them a pharmacogenetic report that is like you were describing earlier on, like quite focused on, this is the advice, less focused on giving them very complex genetic data. And the rest, 1,600 patients, will get treatment as usual. And then we measure a range of clinical outcomes of side effects, adverse drug reactions, and health economics. This is Rosemary Abidov, who is the coordinator, the trial coordinator. And so far, we have recruited 320 patients to offer the intervention. And our clinician recruitment has totally exceeded expectations. We were hoping to recruit in the region of 50 clinicians, but we're now way over that, and the interest has been massive. And we're recruiting all over England. In terms of technologies, we'll try anything that we possibly can. One of the aspects is compare different technologies with regards to cost effectiveness. And for certain things, arrays would be really the way to go. I think in terms of giving data to our clinicians, we are mostly using array data. This work is led by Marius Kotik, who is another PhD student in my team, and he's doing all the molecular work that we do in-house and some stuff we do outside. But basically, gene panels, obviously, they're very cost-effective. They're very good to give a clinician something clear and something actionable and something that they can do something about. But of course, we've also used PCR methods just to compare. And we're obviously very, very keen to use arrays. That's more for the mechanistic research. There's some genes that have limited evidence, so we think that the array data can help us perhaps build up evidence for other genes like CYP1A2, CYP3A4, CYP3A5, and other genes. But of course, there's now arrays. So the CYP2D6 is a very tricky region, as we all know, and the arrays so far have not done so well, but there's now add-on pharmacogenetic content in these arrays that looks very promising. We have, of course, found some of these complex variants that John was alluding to, like complex copy number variants, hybrid genes that are very, very tricky to crack. And for that, again, we are comparing all the different technologies. Where we can't get a good result, we use long-read sequencing, very much with this approach that we start with the least expensive test that we give everybody, and then as we find problems, we build up to the more expensive tests. And this is some preliminary data on our study participants at baseline. We have a very good diversity. I think one of the strengths of the study is its diversity. Good gender balance, a wide age range. Our most senior participant is 91 years old. We do adults, and I'm kind of working with colleagues to expand to be able to include slightly younger people, build our way down the age, and also to include people with intellectual disabilities who might have difficulty consenting. So we're working on those aspects to be more inclusive. But the best aspect of the study is that more than 30% of the participants do not identify as European. And then finally, this is some preliminary data that has been developed by Lauren Varney, who is a research assistant in my team. And if we use a very focused panel for psychosis, just with the couple of genes that have a guideline from CPIC or from the Dutch team, then you really get quite a mixed picture. If you only look at a couple of genes, you can only really provide, you only find that half of the sample has some kind of actionable variant. The figure isn't there. But if you look at a wider panel, if you look at a panel with 6 genes that covers antidepressants, antipsychotics, anti-manic agents, I know there's colleagues in the audience that are working on carbamazepine and HLA. And so if you do look at this broader mental health panel, then most of the participants in the study, more than 93% of them, get some kind of action. We find that they have one or more actionable variants that then we can give the clinician something to do with. In fact, some people end up having 2 or 3 or even 4 actionable variants. So clearly the way to go in terms of feeding information to the clinicians is a panel. But of course, the arrays are very promising for new discovery and for building up the guidelines. And finally, just to thank a lot of colleagues involved in the study. Some of them are experts by experience that have been guiding us as to what to do, what not to do, and pharmacists, geneticists, and some colleagues working in mental health as well. Thank you very much.
Time for questions.
Given we know the rates of non-adherence to treatment are really high in people taking medicines for mental health problems, are you going to be able to tease out the extent to which improvements are due to better use of medicines or to actual, real metabolic effects? Can you tease that out? Is that going to be built into your study?
Yes, absolutely.
Brilliant.
Yeah.
How are you doing that?
Thank you so much. I mean, it's a really important question. I think in psychosis, the rate of discontinuation is massive. Over a period of 2 years, more than half the patients will stop taking their meds. I mean, that is bread and butter for us. Adherence is a massive problem. And then, of course, they relapse and then they get readmitted. And it makes the treatment ineffective and it causes massive expense to the NHS. So it's a massive issue. We monitor the adherence. Oh, sorry. We monitor the adherence as part of the study. So we give them, there's a very nice scale, which I can't remember exactly what it's called, but it's a 10-item adherence measure. And that's one of the outcomes that we measure, absolutely. And one of the objectives of the study is assess the acceptability of the intervention, because of historical things with eugenics. I think some people are a bit suspicious in mental health of genomics, so that's something that is not palatable, but is there. So adherence to treatment, acceptability of the intervention is, and of course there's the issue as well that we sometimes adherence is mandated through the Mental Health Act. That, again, is part of my job, very different to other specialities where everything is voluntary. So I sometimes have to treat people who don't want to be treated. And so, yeah, the adherence, consent, these are massive issues for us. So we are monitoring it as one of our secondary outcomes. To be honest, in terms of if pharmacogenetics helps with adherence, I think that is a big success. So if part of its improvement is directly reducing toxicity, improving how we trying to find the drug that is most likely to work, I'm more skeptical that we'll be able to do much of that. But if we reduce toxicity and we increase adherence, that's already a massive improvement.
Great. Thank you very much, Elvira. I think we are running out of time. Yeah, thanks very much. Elvira is around, so you can ask questions. So, Bill is now going to give 2 talks. So I'll let you get on. So we'll both.
Absolutely. Well, we'll run them through. I'm just going to talk a little bit about one of the work packages that we've focused on. We've got a particular interest in point of care pharmacogenetic testing, and just to clarify what is meant by a point of care test. So this is a machine that's contained that you would want to work with unprocessed samples, so that could be blood or swabs, urine, cheek swabs, etc. It should be non-sophisticated. You shouldn't need lots of training and be complicated to use. You shouldn't need to intervene with the machine at lots of different steps. So you start it, do something, stop it, do something again. You put something in, you get a result at the other end. And it shouldn't need lots of calibration. You need to do checks to make sure it works. And then the results coming out the other end should be very straightforward. So actually quite different from what you are used to in a traditional genomics laboratory, where all of those steps are quite complicated and complex and need different levels of expertise. And point of care testing has been used in lots of different scenarios. Here criteria from infectious diseases and sexually transmitted diseases that you want that assay, that machine, that setup to be affordable. You want it to be sensitive and specific, so it matches what you would get in a traditional laboratory. You want it to be easy to use. You want it to be rapid, so that you get the results in a time frame that is helpful, not lots of different bits of equipment and things that you need to sort out, and you need it to be available in the clinical setting where that's appropriate. And so if you think about point of care testing, well, actually, there's loads of it going on in healthcare. It's the biggest area of diagnostics. So about 30% of all the diagnostics we use are point of care. So what are they? They're like pregnancy tests, they're glucose tests, they're blood gas monitoring, and they're used in lots of different areas. But if you look at the area of biggest growth around diagnostics, it's in genomics. And so you can see a combination of those two things, which is only just starting to emerge. So if you're thinking about a genetic point of care test, there are usually some things that are slightly different from other tests, because you've got to access the genetic material, the DNA, the RNA, whatever it is. Usually you've got to do a process where you amplify up or make lots of copies of the bit of the genome that you're interested in, so then you can do the assay to detect some difference. And nearly all of these tests so far have been developed around infectious diseases. So viruses, how you detect those. Of course, we saw a huge explosion of this area of interest around the SARS pandemic. And that has made a lot of companies think, well, we can do this, we can make these machines. What other areas might they be relevant for in healthcare and in genetics? And so pharmacogenetics absolutely lends itself to that. So when do you think you might use a pharmacogenetic test as a point of care test? Well, it's when you need a result very quickly. So in the context of pain relief, in the context of emergency surgery or in accident and emergency, or in the context of convenience. A patient comes along to their GP, they want to start a new medication, they'd like that information in a quick scenario. So you can talk about preemptive testing, you can talk about planned reuse, as John mentioned, but you could, in theory, think about a test that gives you a result quickly that a patient can go away with the appropriate prescription. But there are lots of barriers to that. There's a lack of familiarity. We haven't used genetic tests as point of care tests. There's always the issues around how you get the funding, how you commission it, that there are lots of pressures within the NHS. How you train people to feel confident that this is a type of test that they can use in their own clinical practice. And so when you look at who would be using this testing in a hospital setting, often it's going to be a nurse, it's going to be a medical assistant, it's going to be a physician. Increasingly, it could be pharmacists that might be using it, and particularly in the community setting. And so there are lots of different technologies that you could use to develop a point-of-care test, and there are loads of companies, small biotech companies, chemists, physicists, different biosensor groups, thinking of different ways of detecting changes in DNA rapidly. So there has been some work over the last decade in this space. Some of you will be aware of this company, Spartan DX, now called Genomatics, who have done a lot of work around CYP2C19 testing, particularly in the context of clopidogrel, and particularly in coronary artery disease, done some work at the Mayo, which is all published. Munir's done some very nice work in the context of warfarin and doing testing in hematology clinics. Some of the challenges there are outside the sort of process of rapid point-of-care testing. It's the fact that warfarin's not used so much. There's been a change in the types of drugs that are used in that setting. But there were some really interesting sort of learnings from that work, which were particularly around, does this disrupt the normal flow of clinical practice? For the nurses and the team in the clinic, were the results coming back in a timely way? Did it mean that people were waiting for those? Or can you embed it into the normal workflow? So we've done a lot of work over the last few years in the context of gentamicin, aminoglycosides, and hearing loss. And I'm going to concentrate on that for the next few minutes and tell you a little bit about where that work's going, because I think it's quite instructive and illustrates some of the challenges. So as you know, about 1 in 500 people carry a mitochondrial change that predisposes to sensory neural hearing loss. That's been known for over 30 years, some seminal work in the 1990s. The incidence, prevalence of that variant is pretty similar across the world, so this isn't just a UK issue. And if you look at NICE guidance, they recommend gentamicin for babies either suspected of sepsis or who have sepsis in combination with benzoyl penicillin. But the problem is, as you know, that you need to give that antibiotic within an hour. If you standardly do genetic testing, it normally takes a few days at best, and so you just don't have the information available to you. You could test all of the mums, because the mum's, if she carries the genetic change, the baby's going to carry the genetic change because it's a mitochondrial variant. But the problem is, does that information always follow the mum? Is it in the baby's new hospital record at the time that it's required? And then you're testing the whole population when it's probably only 10% that need that information because they're the only people that are going to be getting gentamicin. So on a worldwide level, there's about 7 million babies every year that are given gentamicin. So if you could intervene, you could probably stop somewhere up to 14,000 babies every year going deaf. So we worked with a small biotech company called GeneDrive in Manchester, optimized a testing process initially using PCR. We shifted to a LAMP-based assay to increase or to reduce the time that it took to get a result. And in a laboratory setting, we were able to show with lots of controls, lots of different samples, that we were able to get absolute concordance in 25 minutes. So that sounds great in a lab setting, but what we wanted to do was to see, does that really work in clinical practice? So you may have heard that we designed and were funded to deliver a program called PALO, and what we wanted to do, babies are born, they're taken to the neonatal unit, you have a number of swabs taken at that time to check for infection. We wanted to integrate the cheek swab for the genetic test at exactly the same time at admission. It's popped into the machine, nurse goes away, 25 minutes later, the results available, you can use that to inform prescription. So can you do that in the middle of the night on a busy ward when there's lots of other stuff happening? So we recruited over an 11-month period through the COVID pandemic, 750 babies, and of those, a number of them started on antibiotics. There were a number of test fails, I'll come on to that. There were only a tiny number of babies that we didn't do the test on. So that shows how well integrated it was into the routine clinical practice. So of those, we were able to generate a result in 80% of the babies. Of those, 408 were negative, and when we tested those, all 408 were negative. So there were true negatives, so we didn't miss any babies. There were 8 positive samples out of that, so that was more than we expected. I was telling you it's 1 in 500 is the frequency. So there were some false positives within that, but the assay was designed so that we would, if anything, find a false positive rather than a false negative. Because if we found a false positive, they'd still get an antibiotic. The antibiotic would work. The main reason you don't give an alternative antibiotic, gentamicin, is because of the worry of resistance. Okay, so gentamicin is a very good drug in that regard. So all of those babies, those 8 babies, all got given an alternative, and we didn't miss any. So it was great. Sensitivity was 100%, specificity 98%. And the key, well, some of the key learning about that was that when we looked at the false positives, what was the reason? So one of the reasons for the false positives was that there was light coming into the machine when the light was going on within the place where the testing was happening in the middle of the night. It was a motion-censored light switch. So as the nurse walked into the room, light went on, light got into the machine, triggered a fluorescent signal, false positive. Okay, we were able to close off the machine, and that's not happened since. So that's great learning, because if you're doing that in a laboratory testing, no one's turning the lights on and off in the middle of the day or going into cupboards or whatever. But in a ward, that happens. Lights go on, lights go off. The test failure rate, we were able to correct with the company by just adding a stabilizer to the assay mix, and that's reduced that significantly as well. So taking that learning iteratively through the process, it was really valuable in this type of implementation study. It was key to see that nearly all of the babies had the swab taken within the first few minutes of arriving on the ward. So it shows you that it was integrated into clinical care. And the key point we found was that before we did any testing, the average time to getting the antibiotics into the baby was like 55 minutes. During the study, it was 56 minutes. So no meaningful difference in how long it took the babies, because that was one of the real concerns. Is there going to be lots of delays? You're faffing about with this new test. Is it going to just stop the baby getting their antibiotics? And that didn't happen. So that's really important. So we published that. You can look at all of the data around that. And it was really positive to see how positive and engaged the staff were, the nurses that were delivering this process, but also the parents whose babies were having this testing. They thought, this is making a real difference. You're trying to avoid something that is, an avoidable concern. So the things that we've done since the publication, because sometimes that's the problem with research. Things stop there. You get a paper, that's great, whatever, but will this really happen in clinical practice? So we've been working with sort of organisations to develop guidelines. So CPIC, as you've heard, we've got international guidance there. The MHRA have brought out guidance around what you should do in the context of knowing this information, this genotype information, and avoiding gentamicin or an aminoglycoside if it's clinically possible to do that. There are rare situations where actually there isn't a good alternative, so you've got to give gentamicin and take that risk. Also, you can imagine, you say, oh, there's a new test, new machines, lots of assays, it's going to be really expensive. What's the health economic impact? Well, there is a cost to introducing this testing, but there wasn't an additional staff cost. We didn't need to employ lots of extra people to deliver the test, so that's great. The second thing is, if you look at the savings in the context of the babies that won't go deaf, that won't need to have bilateral cochlear implantation, which is the standard of care with profound or severe hearing loss, the overall savings we estimate from an initial analysis is somewhere between £5 and £7 million a year. So it's cost positive. So NICE have undertaken an evaluation of that. It's called an early value assessment, where they've looked at that. What they've done is they've undertaken this process because there's only one study out there. Normally they want lots of studies from different places before they'll look at the evidence, but they wanted to move on this quickly. We've been working with Health Innovation Manchester to roll it out to neonatal units across the region and take that learning. And NICE, as part of their process, produce what's called an evidence gap. So they're sort of basically saying, well, there are these things that we'd like to know before we can progress it. Can it work in other parts of the country? Can it work in different size units? And so there's this funding call that's out at the moment. So we're working actively towards an application at the end of the month to put together what's a 2-year program of work that we would look at rolling this testing out at multiple sites in Wales, Scotland, Northern Ireland, and England. These will be different size units. We'll be able to go back and check, is the fail rate the same? Do we get false positives? Do we get any false negatives? Is there health economic analysis standing up in all of those other centres? We're making sure that we've got parental and staff attitudes across the piece, working with a PPIE programme and hoping to move towards that commissioning place. So I think what we see that at the moment, there are very few examples of where point-of-care testing is used in pharmacogenetics. I think that there's opportunity for that to increase. Now, of course, if we get to a stage, in the future where we've got preemptive testing available to everyone in our record, of course, that's great. We don't necessarily need point-of-care testing, but I think there's going to be a significant window until we get to that point. There's huge differences in technology that are starting to emerge. So we've been working with companies that have been very focused on LAMP or PCR-based assays, but there will be new methods of detection that will be quicker, higher throughput, allow you to look at different types of variants, so copy number changes, etc. At the moment, the tests are all very focused on single nucleotide changes. And it's about thinking, where would you want to use that test? So starting to have conversations with colleagues in stroke medicine around clopidogrel testing, because actually that changes the clinical pathway. So I'm going to stop there. There's huge numbers of people that have worked and contributed to all that work and funding people, but I'm happy to answer any quick questions around Palo, around the point-of-care testing and some of the opportunities in there. And one of the reasons we wanted to include that, or actually the NHS team wanted us to include it in our programme of work, is because it's moved so quickly and it's moved so far that we don't want to just leave it before it's fully implemented in clinical practice. So it's getting that final piece of information to get it over the line and then adopted into clinical care. Thank you. There's a question at the back from Jivan.
Thank you. Great presentation. I may have missed it, but for the babies that had a failed result, what happened? Did they get the alternative antibiotic?
Yeah, so for fails, you didn't miss it, I didn't say, because that was the standard of care prior, and in most centres around the country, there is no testing, and so the approach was to go to standard of testing, well, standard of care, which was just to give gentamicin and benzylpenicillin. Ideally, that's what we wanted to move away from in the future. We know the fail rate has dropped significantly in subsequent iterations. We need to prove that evidence, show that evidence to NICE and NIHR.
Quick question, Bill. Very nice talk. If the test is rolled out more widely and you get NICE approval, does that mean that it could potentially be used on older patients who are starting on gentamicin for other reasons? Because to me, that would probably be beneficial, although I appreciate that aminoglycosides generally are not used that much elsewhere in the NHS.
No, it's a great question. It's an absolutely great question. So there's sort of a number of elements to that. So there's lots of gentamicin that's used in a non-acute setting, and standard genetic testing is available through the test directory. So for children diagnosed with cystic fibrosis or with bladder problems, etc., you know they're going to be prescribed an aminoglycoside at some stage. So actually going through the normal test pathway is appropriate for those. We've done some work to look at what other acute settings is gentamicin used in across the hospital. It's used in adult care, particularly patients having a pacemaker put in, or a particular intervention like that. It's used a lot in paediatric care. One of the things that we've been talking a lot at within the Palo UK study that we're designing is with neonatal teams that not every baby that is started on gentamicin or is considered for gentamicin goes on to a neonatal unit. They may be assessed on a postnatal ward, and so actually broadening the clinical indications is going to be really important, and making sure that we wanted a very clean, focused pathway, but actually you're right, there are a number of other clinical scenarios where this pathway should be thought about.
So, Bill, what do we know about the penetrance of this? and also, when I use gentamicin in my patients, it's usually a single dose when they're coming in with another infection, and then give them a different antibiotic. Will a single dose of gentamicin going to do it as well?
Yes. So the second question, a bit of your question I'll answer. There are documented cases where a single dose has led to profound irreversible ototoxicity. All the initial work was very much case reports, huge ascertainment bias, 100% penetrance. We know that it isn't 100% penetrance. One of the pieces of work we're going to do within the next phase of the programme is to do some more sophisticated modelling and look at what the health economic profile would look at different penetrance levels. Our initial thinking is even down at 50% penetrance, you're still going to see a cost benefit in this setting. So, yeah, you're right. Unfortunately, the ship has sailed, and we can't ever do that study to find out if it's penetrant or not, because it just the clinical equipoise has gone. Lovely. I'm going to jump on. I've just got a couple of slides. Perfect. Okay, because I know I'm eating into your lunch period. Just to talk about our initial thoughts about what it's possible to do within this network of excellence, and to give you a sense of how we see it, and hopefully be guided by you also as to how this network is going to develop over the next little bit. So you can see already from this morning, there's a huge program of work. And even then, we haven't covered everything. There's a whole load of things that you in the room will be interested in that we haven't even touched on. The funding is for 2 years. 2 years flies by really quickly. So, we've got, we've got some clear ideas about what we can achieve, but we know we won't have finished everything. So what are we going to do at the end of the 2 years? We need to start thinking about that. Will there be future funding for networks of excellence? Maybe not, we don't know, but we've got to try to build something that's robust and that just doesn't stop and fall off a cliff in 2 years' time. Myself, Munir knows loads of stuff. I know far less stuff, but the fact is that we still probably don't know all of the people around the country doing all of the pharmacogenetics work. And that's what we want to do. We do not want to own, control pharmacogenetics. We don't want to tell people what they can and what they can't do. What we want to do is to be aware of that. We want to support it. We want to share some of our experience and to link with people. Already in the last few weeks, I've had really great conversations with Somnath and his team over in Brighton, thinking about how we might be able to support their work. I don't know if Guru's here from Nottingham, but having some conversations with him. There are lots of people who are doing work that is really interesting. It's at this point where we think that implementation, moving it into clinical practice, is absolutely where we're at. So that's what we want to do over the next little while. I've already told you about some of the things that we've already started thinking about and considering. These are ongoing conversations, that there will be others that, at the beginning of a 2-year program, we can't predict all of the things that are going to crop up. And we want to be nimble to be able to react to new ideas, new scenarios that we think, as a sort of expert multidisciplinary group, that we can contribute to. So, there is funding. There is funding for the work packages that have been described. Not all of the work packages have got dedicated funding coming to them. Some of them are funded from other areas. So there's some of the mental health work from Alan is funded through the EU Horizon programme. We've got other grants, and so it's about maximising how we use the money. We don't want to just use the money when we've already got funding to do it, but we want to use it as a bit of a catalyst to get other funding in, working with industry, working with the research councils, with charities, etc. We're really keen to think about what, today's a great start. It's been wonderful to see people from lots of different fields, different disciplines, thinking about pharmacogenetics in different ways. But we're really keen to hear from you about what you would like future events to look like. Are there things that you want us to drill down on, things that you want us to spend a whole day on or a half day on? Are there workshops that you want to have around diagnostics, around informatics, around where in the clinical pathway the pharmacogenetic testing should happen, which clinical groups we should interact with. If you are putting in an application, we don't need to be a partner, we don't need to be a co-applicant, we don't need to be a collaborator, but we're really happy to help in any of those capacities if we can, provide letters of support, provide input, and try and share some of our experience if that's helpful. And so, I'm not going to go through a sort of full exhaustive list of all the things we could do, but please do contact myself, contact Munir, contact members of our team. We're starting to appoint people as a central group, and so we'll have points of contact, we'll have some web presence as well, and so that you can feel that you can connect with us, and we'll try and have sort of regular sort of touch points so that you can connect with us. So I'm going to stop there. I'm happy to answer any questions if there's immediate things that people would like to ask.
Thanks, Bill. Any questions on the Network of Excellence?
Thanks, Munir. So, workshops. A workshop on the pathway to implementation in the NHS would be really great, I think.
Yes, I mean, that's a huge topic, and it can be broken down into so many different levels. And one of the things I think that we found challenging, and is challenging within NHS, is to know where some of this sits. Because, you know, pharmacogenetic testing, you know, some of it sits clearly within the Genomic Laboratory Hub program. You can order, if there's a new test that you want, you think it's relevant, you can apply to be part of that, you can get it nationally commissioned. You know, that's a really positive thing. You know, I can't emphasize how in England that is a clear pathway that you might not always agree with the decisions, but you can see that that's a process that you can apply to. For the point of care testing, I think that's challenging because, you know, you know, the testing clearly happens in neonatal units, as Anne touched on. The testing could be in lots of different places around a hospital. Who's going to pay for that? Is that going to become at an IRB level? Is it going to be nationally commissioned? Is it going to be specialist? There is a lot of uncertainty around that. So that commissioning piece is hard. I think it's much easier to talk about, well, what are all those bits of evidence you need to put in place so that actually the commissioners can turn around and say, right, that's all we wanted. And I think, and they've ticked it all off. And the process we've seen through NICE for the point of care test has been incredibly valuable to us. That they've turned around and said, this is the evidence we want you to show. They've given us an evidence plan. We've designed a study to try and show that. And hopefully, once we've addressed that, then they will be in a position they feel confident to give the approval, and then everything triggers and follows from there.
Okay, last question.
So coming in from the NHS GLH hat on, I think one big improvement and how we're going to move this forward would be to, as I think John was saying, this is not the same as a rare disease or cancer test, and removing clinical scientist interpretation of genotype results. So basically having this a validated informatics solution where whatever technology we're currently using, and yes, we still need to, you know, future-proof and have a more high throughput sort of technologies implementation. But before even that, we're all delivering genotypes which are still reviewed by clinical scientists. So scaling up, and this is why, you know, we can't implement the next two ones, which have now been NICE recommended because there is just no capacity. We're following the processes which are not fit for purpose. So I think, I don't know whether it's going to come up in the workshops this afternoon, but some sort of workshop around that would be.
Great, thank you. Yeah.
You mentioned the workshops.
Perfect. Yeah, no, I completely agree. And John touched on there'll be a tiny number of genetic results that might need extra interpretation, further work, etc. But we need to think about this in some ways, like the process I was saying to Jess before, about like a biochemistry lab, how they turn around results. That's not to say the quality isn't there. The quality absolutely is there, but it's just a different way of thinking about the scale and the throughput.
Great. Thank you very much, Bill.
Thanks so much.